I'd like to thank Michelle and the organizing committee for the opportunity to summarize the meeting. It was an exceptional meeting. Um, and I apologize in advance to anyone whose work I was unable to include in the summary because of the allotted time. I think where we are is quite a long way from where we were back when Andrew Lister published the Cotswolds meeting and had that dreadful term, the CRU, which was patients with pretreatment bulky disease, a residual mass post-treatment with no impact on outcome. Because we didn't have appropriate imaging techniques, when we published the first response criteria for lymphoma, we included CRU, which was misinterpreted in many ways and just caused confusion. And then came the PET scan. This has, as we all know, revolutionized the world of lymphoma as well as other tumors, and has really brought us to where we are today. In 2005, we published a paper demonstrating that patients who had a CR by the International Working Group criteria and a PET CR did extremely well with their diffuse large B-cell lymphoma. And so did patients who had a PR by CT criteria, but had a CR by PET criteria, supporting the fact that a PET scan was able to distinguish active disease from fibrosis or sclerosis. This led to the next set of response criteria, which were primarily for large cell lymphoma and Hodgkin lymphoma, because that's where we had all the data, and finally included PET scans as part of standard response criteria, but in those days by visual interpretation. As soon as you put out a set of criteria, you realize that you've got to update them. And we recognized that very quickly because there were now the Deauville criteria to standardize interpretation of scans. And we had more experience in other lymphoma histologies such as follicular lymphoma. So we published a companion set of papers, Sally leading the role of imaging, and the other was the so-called Lugano classification. And those were mostly for end of treatment interpretation of response. But there was a great deal of interest in interim scanning to see if we could affect patients' outcome either by decreasing therapy in low-risk patients or augmenting it in high-risk patients. But we found that the interim scan didn't always predict outcome. And then several studies demonstrated that we were using visual analysis and using it that way. We really didn't do very well compared with the delta SUV. And in this study by Lin and Edie, it just showed how much more sensitive the delta SUV was as a measure. And this has not yet been incorporated into enough clinical trials, but I expect we will be doing so with the next iteration of the Lugano classification 2.0. And in this paper that Heiko published from our group in the CALGB, you can see on the left interim scanning using a Deauville score didn't really predict outcome, whereas if you use the delta SUV, it certainly did predict outcome. Well, end of treatment isn't good enough because patients have already either succeeded or been failed by their therapy. Interim already allows patients who have had multiple prior cycles of treatment. So the focus is now appropriately on baseline efforts to predict outcome. Anna Segaline Cotero and Michelle and their group have published a number of very important papers in various lymphoma histologies showing that baseline metabolic tumor volume predicts outcome. This is one in large cell lymphoma. It's been seen in primary mediastinal, follicular, Hodgkin's, et cetera. At this meeting, Dr. Kanoon published his abstract and presented the paper looking at total metabolic tumor volume in advanced Hodgkin lymphoma from the AHL2011 study. On the left, you can see the total metabolic tumor volume in the validation set, showing a distinction between high and low. And when you incorporate PET2, you get a further discrimination with a third group, which has a poorer outcome than the first two. However, that group does not have a sufficiently worse outcome to really give us a handle on how we can do a risk-adapted approach. So we clearly need to add other factors. No treatment in my recent memory, and I seem to be losing my recent memory, has stimulated the amount of enthusiasm as CAR T cell. These are some data from AxiCell, and it shows the results of patients who would have been eligible for clinical trial in the blue curves or ineligible because of comorbidities, age, or the like. And you can see that the results that we always quote are the blue line, but there are patients who really don't do as well. Well, that's one way to determine who might benefit or not from CAR T cell. And the long-term follow-up shows that only about 31% of patients at 5 years are still progression-free. Now, this therapy is toxic, it's expensive, and it's not uniformly available. So we need other ways to predict how patients might benefit. And in these data from Versalino et al., they identified 3 factors: extranodal sites, 2 or more, high CRP, and metabolic tumor volume using the, as we heard at this meeting, outmoded 41%, can divide patients into 3 risk groups who have a very distinct progression-free survival probability and might guide who we refer for this therapy. And if you look at the Deauville score at 1 month, you can see that PET really does predict, in the work of Catherine Teblemont, the outcome with regards to progression-free survival. So baseline total metabolic tumor volume before CAR T infusion has a strong prognostic value in patients with relapsed refractory large cell treated with CAR T. The response assessment based on PET at 1 month on the delta SUV is strongly associated with PFS and overall survival. And the Deauville criteria with stratification DS1 to 4 versus DS5 at 1 month allowed to discriminate outcome even in patients with a low TMTV. So as Irene said, recent literature has confirmed that TMTV is useful. The problem with the cutoff value is not yet solved even with AI. And 2 complementary approaches are ongoing, working together on finding a single consensus method and sharing data to identify the cutoff best suited to the adopted segmentation method. And this will be discussed in great detail, I'm sure, at the next iteration of PILM. We heard an awful lot about radiomics, something we didn't even talk about a couple of years ago. Dissemination has been widely lauded as a very powerful predictive measurement. And looking at either the LNH-073b or the REMARK study, you can see that both PFS and overall survival correlate very well with the Dmax. And you just heard, since I didn't know he was getting an award and presenting this to everybody, congratulations, Dr. Dermo. You heard that dissemination in advanced Hodgkin lymphoma is also important. You can see in this study, half the patients had advanced disease and half not. And the Dmax correlated nicely with advanced risk, IPS score, and total metabolic tumor volume. As you saw, that patients with a high Dmax had an inferior 5-year progression-free survival compared to those with low. And the combination of interim PET and DMAX identified two distinct groups of patients who were interim PET negative based on their DMAX, which might indeed lead to risk-adapted therapy. And what we've also heard is that there are almost countless measures of radiomics. You heard from Dr. Ertink that there were numerous dissemination intensity, 3 volume, 4 distance. And when you combine the radiomics with MIC and clinical versions, you get a better sensitivity than either of those subsets alone. And there are some other radiomic measures, and Dr. Chimbari showed her data and just presented it very nicely, looking at diameter, skewness, and kurtosis, and showed correlations in Hodgkin lymphoma, which might also allow us rich risk-adapted approaches. There are even data looking at high adipose density having a strong prognostic value in large cell lymphoma. And you can see on the right the PFS and OS based on the fat content. It seems like there is considerable interest in combining a number of these measures that I mentioned, such as metabolic tumor volume and heterogeneity, as has been done by the SAC group and presented during this meeting, looking at overall survival, progression-free survival, showing discrimination. But when you combine the two, you can really identify one group of patients that does extremely poorly and might be afforded a different treatment option. But what has been a consistent observation is that there are numerous of these combinations that have been offered, and they all seem to be superior in prognostic impact to the IPI and the NCCN IPI. So a clear move forward in prognostic implications. And you saw this earlier that there in the HOVON 84 trial, they looked at 490 radiomics features, but the MTV had the AUC of 0.66, and there was nothing better no matter what combination you used. So the best radiomic model in this evaluation was TMTV, SUV peak, and DMAX. And there was no added value of textural features from a single lesion. So features at the lesion level, the lymphoma is mainly a diffuse disease with no clear consensus on the best target lesion. Heterogeneity of signal intensity deserves further invitation. For more than hundreds of features, no single textural feature clearly stands out. No radiomic signature validated by several independent groups, often not well described, and radiomic models should be explicitly described so they can be tested by different groups. And features at the patient level, the TMTV is essential to study at baseline. Dissemination features such as DMAX are very important, and the heterogeneity of signal intensity at the patient level has not been widely studied yet. Now, you just heard an outstanding presentation on circulating tumor DNA. This has been shown to have powerful prognostic impact in patients with a number of histologies, follicular, and in this study from Kurtz and coworkers, before treatment in patients with diffuse large B-cell lymphoma. It correlates with total metabolic tumor volume, as you can see on the left, and affords us opportunities for additional combinations of prognostic factors. There's TMTV plus performance status plus distance, and now we have circulating tumor DNA as well. And again, another study showing that it is consistently higher in patients with a high total metabolic tumor volume. And in an older study from Blood Advances 3 years ago, the combination of high total metabolic tumor volume and high circulating tumor DNA in patients with follicular lymphoma was associated with a much poorer outcome than the other combinations of factors. And in the excellent presentation by Dr. Shaybani, you could see the total and nodal metabolic tumor volume correlating strongly with circulating tumor DNA, regardless of spleen inclusion, but in contrast, extranodal disease did not correlate as well, with lots of exciting research to follow. I don't think it's ready to put us out of work yet, but artificial intelligence and deep learning are really becoming an area of interest in lymphoma. And from Lali's presentation, she described the differences between artificial intelligence, machine learning, and deep learning, which I won't take the time to go over again. In the presentation at these meetings by Reveler and Canoon, the two scans on the left are manual, and the three on the right are the artificial intelligence. And you can see the correlations are very high, 0.92, 90, and 97 with the Pearson, showing a possibility that this could be something to look forward to in the future. And in the poster from Dr. Triambari, she also showed that using a neural network model, it performed better than the multi-regression models to predict time to event in patients with residual FDG uptake for their large cell lymphoma. We saw the elegant presentation describing what you all go through, trying to get total metabolic tumor volume, having the automated contouring, removing the physiological uptake, and spending a lot of time for each physiologic uptake site. But now, in the presentation by Capobianco showed that there's a good correlation between expert segmentation and CNN segmentation. And you can see on the right the correlation between progression-free and overall survival, whether it was based on expert or AI segmentation. But as Lali reviewed, there are a number of challenges. It's an emerging field. There are differences in algorithms, heavy manual labor to set it up, questions of generalizability, expense, resources, and the need for big data. But I think we will be adopting this more and more in the future. So PET is the foundation for prognosis and response assessment now. There are other factors to improve the power: total metabolic tumor volume, distance, radiomics, but the optimal combination remains to be determined. We need to understand the differences amongst histologic, genomic, and biological subtypes that are reflected in differences in distance, radiomics, and metabolic tumor volume. AI and deep learning may enhance the ability over manual determinations, but we need larger collaborative efforts towards standardization, not only of AI, but of TMTV and other radiomics. And we need to apply these technologies to patient management. And here's just a suggested strategy. As we mentioned yesterday in the discussion, we tend to wait till 4 cycles or 2 cycles with our interim scans and decide what to do at that point. I think we now have the tools to deal with this upfront, whether it be with gene expression profiling, NGS, TMTV, radiomics, or other factors. We can predict patients who will do extremely well with standard approaches or who will do extremely poorly with standard approaches. In the data from Margaret Shipp's group, one cohort has a predicted 0% likelihood of having long-term benefit and others up to 70%. Why do we treat them all the same? So if a patient is likely to do well with standard therapy, we can put them on a trial or treat them with standard drugs, monitor them with MGS, looking for the acquisition of mutations and deal with them if they occur. But a patient who is likely to do poorly with standard therapy should not be subjected to standard therapy and should be put on an investigational protocol, preferably with a non-chemo regimen. And just to show that we are a very all-inclusive collaborative group, there was a nice session on myeloma and PET. This is just one slide to show that they are getting there with regard to their prediction of progression-free survival and the use of bone marrow flow cytometry to predict outcome and perhaps direct treatment. So I again like to thank Michelle, the organizing committee, all the speakers, all the investigators for a wonderful meeting. And hopefully we will see each other soon in Montan, where the scenery is beautiful, the food and wine is superb, and perhaps next time we may even hear a little opera. Thank you.